The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to the Value-Based Payment Practice Transformation Academy webinar, Communicating the Why. My name is Libby Ethier, and I will serve as your moderator today. I am a project coordinator at the National Council for Behavioral Health and for the Practice Transformation Academy. Before we begin, I'd like to bring to your attention that the webinar slides are currently available for download via the webinar navigation page under Handouts. The slides and recording will also be made available on the Academy website within 48 hours. I am joined today by my colleagues from the National Council, Kate Davidson, who is an Assistant Vice President of Practice Improvement, and Tracy Nadinger, Director of Communications. We'll be asking for audience participation, so when the time comes, we encourage you to use the hand icon in the navigation bar to virtually raise your hand if you'd like to speak. We will then unmute you so the rest of the audience can hear you. You can also submit questions and/or comments throughout the webinar via the question box located in the navigation bar. And now I will turn it over to Kate.
Thank you so much, Libby. Welcome to all of you guys to our webinar today. It's been really fun. We've had 4 affinity group calls in the last couple of weeks, and it's been really interesting to hear how people have been making progress on their stretch projects. So thank you guys for participating and being so active. And want to hear a little bit today. In the last webinar, we gave you some homework, and that was to develop an elevator speech, which is defining your stretch project, and then also to begin to think about metrics. So identifying one process level and one outcome level metrics that you're tracking on for your proposed data collection plan. This is all going to tie in together because a lot of what we're focusing on today is how do you talk with your staff about the transformation that is happening within your communities and within the larger system, but most importantly, what's happening within your own organization. So we'll be talking a lot about that today. And so I'm asking folks today to give me a couple of volunteers to tell me how you've defined your stretch project, what your 2-sentence elevator speech is, and then about your metrics that you've outlined. So please go ahead and raise your hand, and once your hand is raised, we'll unmute you, and you can give your quick down and dirty elevator speech about the work that you're doing within your organization. Just need 2 volunteers and get us started today. Anybody, Libby?
It looks like we've got Natalie. I'm going to unmute you, Natalie.
Natalie,
okay.
You are unmuted. Go ahead. Thank you.
All right, so the first one doesn't get judged too harshly, I hope.
No, thank you for sharing.
So I actually had a meeting with my staff yesterday regarding this, and what I did is I talked with my manager, and I really emphasized the fact that the work that we're trying to look at identifying and actually documenting is the work we're already doing.
Yep.
And so I just started off by saying, you know, we do a great job working with the women that we serve in our PPW program, and we really do reduce the number of ER visits during the time that they stay with us, and we educate them about better, you know, self-care, better health care for themselves and their children, and looking at things before they happen rather than after the fact, and just in general better health care. And so I just said, you know, one of the things I want to do in preparation for the changes that are coming that we're going to have to adhere to anyway, I want us to start looking at the things that we do that have an additional value. And so I just kind of started that way with what we already do and how it works for us and how we can document that, and then how we can communicate that to the people that we are working with as far as our payers. Is that kind of what you were talking about?
That is perfect. And I love that you've already started that conversation, because you're absolutely right. It's not a one and done. It's something that evolves over time. And it's something that you will have to keep saying. I mean, I think in our very first meeting together, we talked about 7 times, 7 ways. And so this is just that very first entree into that. And so I'm so glad that you've already started to work with staff to identify that. Thank you so much for sharing, Natalie.
Oh, you're welcome.
All right. We have one other person who wants to share. There's one more volunteer. Oh, looks like we got somebody.
Claudia, I'm going to unmute you. And Claudia, it looks like you haven't put in your audio pin, so if you could just type that into your phone, that would be great, and then we'll be able to hear you.
The other option too, Claudia, is if you want to type in your how you've talked with staff, we're happy to read that out as well.
I'm going to try again.
All right. Now you're on.
Okay.
So this is Claudia, and then one of the things that we had talked about, so the many things that happened for us to try to get ready. We had, I had already convened a different group of different members. We started looking at maybe some of the people who can participate. They can be these clinical leads from the behavioral health team. We also looking at who's going to help us in terms of there is another person, Dr. Gibbs, who worked with us, who's also in charge of all of the key quality improvement with the organization. We think about this he could be a really good part of our team. We also looking at people who are working right in primary care. So we'll start kind of bringing the team together. I have met with the people in behavioral health and kind of go over everything that we had done up to this moment. And we had talked a little bit about the elevator pitch. So one of the things that we had said maybe is kind of really base it into our stretch project and saying we have an integrated approach to deal with the symptoms of depression. We are making sure that we can increase the behavioral health treatment to all clients coming from primary care. That's, basically what we send to everybody. And we say the referral doesn't require a diagnosis of depression. We just want to make sure that if there's any symptom of depression, you can send the patient to us.
That's wonderful. You kind of defined what your bold goal is going to be in a couple of sentences so that everybody knows what your intentions are and what you are setting out to achieve.
Correct.
Thank you so much. I really appreciate you sharing. Right. Well, so, we're going to talk today about how great leaders can inspire action. And both of the examples that we just got were examples of folks that are inspiring their staff, inspiring staff to make these huge transformational shifts. And so we're going to play a clip from a TED Talk that really has inspired me over the last several years to think about the why we do what we do. We've at times had a couple of choppy visuals of this, but the audio should come through very, very clearly. So if you have any problems with audio, please just go ahead and type that into the chat box. But we've tested this a couple times and are pretty confident that this should be good. So go ahead, Libby, and start it.
How do you explain when things don't go as we assume? Or better, how do you explain when others are able to achieve things that seem to defy all of the assumptions? For example, why is Apple so innovative? Year after year after year after year, they're more innovative than all their competition. And yet they're just a computer company. They're just like everyone else. They have the same access to the same talent, the same agencies, the same consultants, the same media. Then why is it that they seem to have something different? Why is it that Martin Luther King led the civil rights movement? He wasn't the only man who suffered in a pre-civil rights America, and he certainly wasn't the only great orator of the day. Why him? And why is it that the Wright brothers were able to figure out controlled powered manned flight when there were certainly other teams who were better qualified, better funded, and they didn't achieve powered manned flight, and the Wright brothers beat them to it? There's something else at play here. About 3.5 years ago, I made a discovery, and this discovery profoundly changed my view on how I thought the world worked, and it even profoundly changed the way in which I operate in it. As it turns out, There's a pattern. As it turns out, all the great and inspiring leaders and organizations in the world, whether it's Apple or Martin Luther King or the Wright brothers, they all think, act, and communicate the exact same way, and it's the complete opposite to everyone else. All I did was codify it. And it's probably the world's simplest idea. I call it the golden circle. Why, how, what? This little idea explains why some organizations and some leaders are able to inspire where others aren't. Let me define the terms really quickly. Every single person, every single organization on the planet knows what they do 100%. Some know how they do it, whether you call it your differentiating value proposition or your proprietary process or your USP. But very, very few people or organizations know why they do what they do. And by why, I don't mean to make a profit. That's a result. It's always a result. By why, I mean what's your purpose? What's your cause? What's your belief? Why does your organization exist? Why do you get out of bed in the morning? And why should anyone care? Well, as a result, the way we think, the way we act, the way we communicate is from the outside in. It's obvious. We go from the clearest thing to the fuzziest thing. But the inspired leaders and the inspired organizations, regardless of their size, regardless of their industry, all think, act, and communicate from the inside out. Let me give you an example. I use Apple because they're easy to understand and everybody gets it. If Apple were like everyone else, a marketing message from them might sound like this. We make great computers. They're beautifully designed, simple to use, and user-friendly. Want to buy one? Meh. And that's how most of us communicate. That's how most marketing is done. That's how most sales is done. And that's how most of us communicate interpersonally. We say what we do. We say how we're different or how we're better, and we expect some sort of behavior, a purchase, a vote, something like that. Here's our new law firm. We have the best lawyers with the biggest clients. We have, we always perform for our clients, do business with us. Here's our new car. It gets great gas mileage. It has, leather seats. Buy our car. But it's uninspiring. Here's how Apple actually communicates. Everything we do, we believe in challenging the status quo. We believe in thinking differently. The way we challenge the status quo is by making our products beautifully designed, simple to use, and user-friendly. We just happen to make great computers. Want to buy one? Totally different, right? You're ready to buy a computer from me. All I did was reverse the order of the information. What it proves to us is that people don't buy what you do, people buy why you do it. People don't buy what you do, they buy why you do it. This explains why every single person in this room is perfectly comfortable buying a computer from Apple. But we're also perfectly comfortable buying an MP3 player from Apple, or a phone from Apple, or a DVR from Apple. But as I said before, Apple's just a computer company. There's nothing that distinguishes them structurally from any of their competitors. Their competitors are all equally qualified to make all of these products. In fact, they tried. A few years ago, Gateway came out with flat-screen TVs. They're eminently qualified to make flat-screen TVs. They've been making flat-screen monitors for years. Nobody bought one. And Dell came out with MP3 players and PDAs. And they make great quality products, and they can make perfectly well-designed products, and nobody bought one. In fact, talking about it now, we can't even imagine buying an MP3 player from Dell. Why would you buy an MP3 player from a computer company? But we do it every day. People don't buy what you do, they buy why you do it. The goal is not to do business with everybody who needs what you have. The goal is to do business with people who believe what you believe. Here's the best part. None of what I'm telling you is my opinion. It's all grounded in the tenets of biology, not psychology, biology. If you look at a cross-section of the human brain, looking from the top down, what you see is the human brain is actually broken into three major components that co-innovate it.
We're going to speed ahead for just a minute. Libby's got it all worked out.
Even now, you ask people, why did your product or why did your company fail? And people always give you the same permutation of the same three things. Undercapitalized, the wrong people, bad market conditions. It's always the same three things. So let's explore that. Samuel Pierpont Langley was given $50,000 by the War Department to figure out this flying machine. Money was no problem. He held a seat at Harvard and worked at the Smithsonian and was extremely well connected. He knew all the big minds of the day. He hired the best minds money could find, and the market conditions were fantastic. The New York Times followed him around everywhere, and everyone was rooting for Langley. And how come we've never heard of Samuel Pierpont Langley? A few hundred miles away in Dayton, Ohio, Orville and Wilbur Wright. They had none of what we consider to be the recipe for success. They had no money. They paid for their dream with the proceeds from their bicycle shop. Not a single person on the Wright brothers' team had a college education, not even Orville or Wilbur. And the New York Times followed them around nowhere. The difference was Orville and Wilbur were driven by a cause, by a purpose, by a belief. They believed that if they could figure out this flying machine, it'll change the course of the world. Samuel Pierpont Langley was different. He wanted to be rich, and he wanted to be famous. He was in pursuit of the result. He was in pursuit of the riches. And lo and behold, look what happened. The people who believed in the Wright brothers' dream worked with them with blood and sweat and tears. The others just worked for the paycheck. And they tell stories of how every time the Wright brothers went out, they would have to take 5 sets of parts because that's how many times they would crash before they came in for supper. And eventually, on December 17th, 1903, the Wright brothers took flight. And no one was there to even experience it. We found out about it a few days later. And further proof that Langley was motivated by the wrong thing, the day the Wright brothers took flight, he quit. He could have said, "That's an amazing discovery, guys. Now we'll improve upon your technology." But he didn't. He wasn't first. He didn't get rich. He didn't get famous. So he quit. People don't buy what you do, they buy why you do it. And if you talk about what you believe, you will attract those who believe what you believe. Well, why is it important to attract those who believe what you believe?
So that's just a short clip that I think, in our industry, in healthcare, and specifically in behavioral health, we are, Libby had me. So in our industry, we are filled and surrounded by passionate people. And in a moment where we're going through such transformation in our system, it's really important to always remember the why and to communicate that why in every interaction that we have with staff. And so we're really lucky today that Tracy has joined us. We have this amazing communications team here at National Council for Behavioral Health, and Tracy is one of our directors, and she's going to talk about how they develop a communication plan, both for our own internal purposes, but also for our external purposes. And the idea here is that you can use some of these concepts to help you to build your communication plans. And then after Tracy's finished talking, I'm going to talk about then how you tie that to value-based payment and transformation. Tracy?
Great. Thanks, Kate. Hi, everyone. This is Tracy. So I'm going to talk about, how do you get to the point where you're communicating the why. So next slide. So I'm going to talk a little bit about the foundation to building your communications plan. So that involves goals, audience, methods, messaging, and evaluation of that plan. So the goal, you want to develop an effective message to communicate the why of value-based payments to your staff and internal stakeholders. How are you going to get buy-in, not only from stakeholders, but also from staff on this new initiative? But before you can really communicate the why, it's important to define who your audience is. And Kate can probably talk about more of this at the ground level. So who is your target audience? Is it staff? Is it agencies board? Is it clients? It could be all. And why should your audience care about this? Are they searching for answers or resources? What problem are you able to solve with value-based payments? And what actions do you want them to take to implement this new payment system?
And is it fair to say too that when you're thinking about your audience that you might actually tweak the way you're messaging based on that audience? Same major theme, but maybe tweak it a little bit?
Yeah. So one of the things when you're defining your audience that you want to think about is tapping into their existing core values. So not the value you want them to have, but the value that they have to create common ground. So this will make them more motivated to act.
Great.
That's a good question. Yeah. So when you're defining your message, you kind of want to ask these 4 questions. You know, we already talked about audience, but what problem are you solving? So basically, how does value-based payments solve a specific problem for the organization, such as reducing costs? What's new about the service? What sets value-based payments apart from other payment models out there? And what's the solution to the problem? The solution would be value-based payments in this scenario. And then you also want to think about what you're going to say in your messaging. So you want to make sure that it's simple, that it's concise, that it's easy to understand, and that it's memorable, so that when people think back on why they invested in value-based payments, they know why based on your messaging. So connecting with your audience and the common ground, having a barrier message which addresses and counters the challenges and misconceptions, and then having an ask. What do you want your audience to do with this information? And anytime you incorporate visuals into your messaging, it really helps people remember what that message is, but also echoes the value of the message. So again, just kind of going over some of the methods when you're sending out your messaging. So being clear, concise, and consistent. Kate can probably talk about ways that we've messaged value-based payments here at the National Council. Repetition works, so work it. Tell them how. Eliminate competing calls to action. Use written and verbal messages. Tell a story. Designate a champion. Maybe look at other organizations or affiliations where this specific model has been successful. Use that to tell a story. People remember stories, and they tend to just be that much more compelling, and they speak to your why, like why you really want to do this. What is the on the ground impact? So that can be a very effective messaging strategy.
Thank you so much, Tracy. Really appreciate that. So in the next couple of minutes, and Tracy, please feel free to add things as I'm talking about how this applies to value-based payment. Next slide, please. So to me, all of the themes that Tracy just talked about, all of the questions that you have to ask yourself with value-based payment readiness, there's such an opportunity here because, we are moving away from this fee-for-service payment, and we're moving toward really incentivizing improved clinical work. And for the most part, I would say for 99.999% of clinicians and the people that we work with, we all got into this work for the right reasons, which was really to improve client care. At the end of the day, that's what we're all passionate about. And so value-based payment and transformation efforts really give us the opportunity to harness the passion that our staff have around quality care. And so this should really be very familiar to you all for several reasons. So this is a way to think about value-based payment readiness, and it aligns with the triple aim, which is really those 3 main drivers that you see there, which is patient and family-centered care design, data-driven quality improvement, sustainable business operations. And so all of those elements, all those core competencies, both are reinforced by the way that CMS thinks about things, so the Centers for Medicare and Medicaid Services, but also about the way that Washington State is really thinking about their preparedness and their roadmap for value-based payment. So that's that piece that Tracy was also talking about with consistency, making sure that all efforts are really aligned. And so it won't come as a surprise to folks that it's also very much aligned with patient-centered medical home change concepts. And it's wonderful that you've got your entire healthcare system in Washington State really aligned with one another. There's 4 practice transformation networks in the state of Washington, and all of them are using this same change concepts to really drive preparedness for value-based payment. So there's that consistency across the board, and it also gives you a common language to speak with your community partners. If everybody's kind of following that same roadmap, then people are able to work together to create and forge community partnerships, as well as forge clinical innovation. Next slide, please. So, you know, really in line with how Simon was talking about that golden circle, you know, thinking about the what. And so before, I'm not necessarily saying that we should start with the what in your pitch, but I think it's important that as a leader within your organization, you have some clarity about what it is that you want to become. And you get to engage staff in that solution, right? So it doesn't just come from a leadership's perspective, but it's how do I ensure that my clinicians, that the folks on the front line are truly engaged in the what? You know, people make fun of me because I was a clinician from the start, but at the end of the day now, I'm really jazzed and excited and passionate about finance reform and healthcare financing, and they sometimes ask me what the connection is. But to me, there's such a clear connection and between how we're thinking about incentivizing payment with improved clinical care. And so you want to make sure that your frontline staff feel that enthusiastic about healthcare financing as well. And I have to laugh when I say that, but if you can really communicate that excitement and get people on board with the solution and about the what and the how they're gonna get there with that roadmap, then I think you're really gonna have a powerful opportunity within your organization. So as most of you guys know, I'm a recovering administrator myself. I ran clinics for several years, and I also prepared my clinic for one of my clinics for value-based payment. And in doing that, one of my first steps, we opened a primary care clinic within our behavioral health clinic, and we were had implemented same-day access and had implemented just-in-time prescribing and had implemented centralized scheduling, and just, you know, all of these pieces that were all kind of coming together that caused a lot of implementation fatigue within our staff and within our organization. And so one of the things that I did, and it sounds like a couple other folks here did a similar exercise, is get all of my supervisors together to talk about mission. And you know, we did at the end of the day really make sure that our therapists and our front office folks and really the entire staff was involved in this, deciding about what our vision was going to be for the next couple of years. But I really wanted to make sure that I had leadership on board so that when I was going into some of these harder conversations with some of the frontline staff that maybe were tired from all of the changes, that I was able to leverage other folks that were already bought in. So, you know, we talked about one of the things, a huge paradigm shift that we knew we needed to make. And that paradigm shift was moving away from our therapists and just the way that our clinic operated, thinking about how the individual was the client, or the individual, that therapist was responsible for an individual, and instead really embracing this new idea that we are responsible for our community. And so it's not just the people that are enrolled in our clinics, but it's truly how do we improve the mental health and wellness and overall wellness for our community. And so we set out to create a vision statement and a goal statement. And here's what we came up with. We decided that we wanted to be the premier healthcare provider for the world's most vulnerable populations. We are innovators in the healthcare space, providing service to people who are otherwise marginalized, and we will not accept that people in our community continue to be marginalized. We are committed to a culture of passionate curiosity, a culture of data-driven decision-making, and we are accountable for the care that we provide. We do not see barriers, we see opportunities. And that was something that I think everybody could really rally around. And it was interesting, that first sentence, that we are the premier healthcare provider for the world's most vulnerable populations, that was a hard fought sentence. I personally fought very hard for taking behavioral health out of the statement, because I thought it was important that we really took accountability and responsibility for the whole health of our patient populations. And it really changed the game. It changed the way that we thought about the services that we were providing, and the responsibility that we had to our community. And what I thought was really cool from my perspective was to be able to watch and hear people communicate this, and with pride. And when you have a vision statement, or when you have a mission that is so clear and people all agree with it, it's really something that people can rally behind. And so I recommend folks are thinking about these things and thinking about how to operationalize this within your own organization. This is a little wordy. I had a hard time making sure that we could cut it down to be a little bit more concise. Maybe Tracy would have helped me do that a little bit, but this is what we landed with. Next slide, please. So I want to return to kind of this how-to around value-based payment. And so we're going to get into some details about the types of payments, the types of value-based payment arrangements, and talk those through, because I do think repetition is important. I know you guys have seen some of this before, but I want to make sure that we're really, really clear on what we're talking about, and that you guys are able to then communicate with your staff about these different types of payment structures, because when they have questions, it's going to be so important that you are able to communicate this sense of calm. That doesn't mean you have to know all the details to everything. You can still have questions, but having a basic framework and feeling confident, I think, is super important as you enter into these conversations. So case rates, they typically refer to a payment for a specific set of services. So it's moving away from fee-for-service. So you provide an intervention and you get a payment linked to that intervention. But instead, the payments are really lumped together in a group. A lot of times we call these case rates because we're taking a look at, or the provider's really being incentivized for the entire caseload. So an example of how we've applied case rates in the past, and an example that I'm going to use a little bit later on today, is through care coordination. And so you might establish, like, for care coordination, here are the different types of activities that you can leverage. You are given that lump sum for a specific time period. Many, many times it's per member per month. And then within that period of time, you must be able to keep that individual healthy. And so that client, in order to stay healthy, might need more services, or they might need less services, but you're really averaging out you're really trying to create an average for that case rate. And that helps you to predict what that case rate setting is. And so, in other words, if you can provide less services within that case rate, then you can actually increase your margins. And so that's really what organizations are thinking about when they're trying to think through what care coordination might look like within their organizations. And oftentimes, this case rate or care coordination is the very first step that people take when they're dipping their toe into value-based payment arrangements. And so folks might want to be looking at how they could be incentivized. And I know that you guys have in the past already have some experience in Washington State with case rates. I know some folks already have some of that experience. And so thinking about how that might look similar in the future, but maybe a little bit different also, and how you can identify what your costs are for a particular service, so that when folks are establishing what the payment would be for a case rate, you know you can reasonably operate within those standards. Next slide. So an episode of care is a payment structure that is triggered by a specific event. And so this could be something that's triggered by a specific diagnosis or by a delivery of a specific service type. You can use it either for an acute diagnosis or for chronic health conditions. So CMS, the Centers for Medicare and Medicaid Services, there's been a lot of effort being put in the direction of identifying what an episode of care for things like total hip or knee replacement might be. Folks can actually see how they've structured those payments. The Learning and Action Network has done a lot of work across the country in trying to bring together best practices in establishing case rates for episodes of care, or I mean not case rates, for defining episodes of care for specific diagnoses. But there's also examples of chronic conditions, so like management of care for people diagnosed with ADHD. And so this is something that I would imagine that is going to be oftentimes prescribed by the state as states are putting structure around what an episode might look like. But it will likely follow the same methodology that CMS has been using to establish those episodes of care. So you really want to be thinking about, how have these things happened in the past when they're defining acute conditions or chronic conditions? That'll give you some intelligence about what are the things that the state of Washington is going to be thinking about as well. Episodes typically have a duration that's defined by that common condition, that chronic condition. So, for example, for ADHD, you could have a year long. So the trigger mark is that you were diagnosed with ADHD, or it's that you get a payment for X number of services to provide services for someone with ADHD for a year-long period. And so it looks a little bit different for an acute condition versus a chronic condition, the way those episodes of care are structured. Next slide, please. And then there's capitated rates or capitation. And so you'll most typically hear about capitation as it relates to managed care organizations. So managed care organizations are tasked to be able to provide coverage for for a particular patient for managing their entire care needs. So they receive a capitated payment, and the managed care organization must absorb all of those costs. Sometimes those managed care organizations will subcontract or subcapitate with large healthcare providers. So what that means is that they will negotiate with potentially maybe a large hospital system or an ACO for all of the services for that individual, or nearly all of those services. And that can include the entire spectrum, right? So it could be inpatient, it can be outpatient, testing, pharmaceutical services. So the difference really between a capitated rate or a capitated payment than a case rate or an episode of care is it's really the spectrum of services that are captured within that capitated rate. And so it's less likely that community behavioral health organizations are going to get to a place where they are taking on full capitation. But what you might find is that you are doing down the road that you might be doing subcapitation with other organizations, maybe even larger healthcare providers, and negotiating some of those rates with them and providing the mental health services in the community. Next slide, please. So there's cross-cutting themes for each of these different types of value-based payment arrangements. One is that you must be able to define your patient population and or the eligibility. So how do you have an idea of who falls within that capitated rate, within that episode of care, within that case rate? Either is there a diagnosis that's triggering it, or what makes them eligible? We're seeing across most value-based payment arrangements that there is a care coordination or a care management component. And so you really want to make sure that you're thinking about the whole health. Even in a situation where you're carved out and you're doing you're responsible for a smaller part of that whole health, you still are going to be thinking about where you fit into that puzzle for that person's whole health. Access to data. So while you're negotiating or while you're thinking about entering into a value-based payment arrangement, you want to make sure that, one, you've defined the metrics, and two, that then you have access to that data. And so I know those are conversations we've been having across the board with folks as you've been thinking about your stretch projects. Is one, define the metrics, thinking about what the state is going to be responsible for, thinking about how what managed care organizations are going to be responsible for, and what clinics are going to be responsible for under Healthier Washington. But in addition to that, how do I access that data? And if I don't have a full data set right now, what are the process level measures that I can be collecting that are going to help to indicate that I'm making movement for the metrics that I'm really going to be responsible for? Value-based payments are oftentimes tied to evidence-based interventions. So people want to fund what works, and they want to be able to make sure that specific patient populations have access to evidence-based interventions. So taking a look at what sorts of evidence-based interventions that you have and that you have staff that are trained in right now or that you have in place right now. For example, operational evidence-based interventions such as same-day access, thinking about how that is something that you can really use to articulate your value proposition. Cost analytics, we talked about what case rates are and wanting to make sure that you that if you are given a case rate that you can actually provide the service and within that case rate. So if you are negotiating something and you're not sure what your cost is in order to provide the services, that puts you at further risk for maybe being responsible for somebody's wellness, and you based on operational efficiencies, you can't be able to actually benchmark change over time. So you have to have access to those cost analytics. So in terms of the importance of accurate data, and I think it's important here to talk about this with staff. So staff oftentimes when I use the word data or when we think about performance metrics, we use that word performance. We use that with organizations, we use that with states, we use that with clinicians, and so that can feel very overwhelming for folks. And so you want to make sure that as you're talking with people, that they understand why you're focusing on data, and that it's really linked back to overall improved clinical care. But then in the end of the day, making sure that data is accurate. So if you're going to be providing clinicians with data, ensuring that the data that you're providing is both consistent and accurate, much like your communications plan, and that's really going to help you to get buy-in. So the importance of accurate data around patient population and the level of intensity of the services that are being provided, as well as the costs of services. And we're going to talk a little bit more about ensuring that down the road about how risk stratification is so important, because at the end of the day, if you don't have a way to stratify risk, you're not going to have a way to build in those population health management approaches, and you won't be able to benchmark change over time and operationalize increasing your margins. And then ultimately the importance of defined care protocols to assure that you're not either underutilizing or overutilizing. We talked, I think, in the first kickoff meeting about how staff really, sometimes we end up seeing those people that are lower risk more frequently in a fee-for-service world. So, for example, if someone has depression and a mild depression, they might be somebody who's coming into the clinic more and more frequently. And so, in a fee-for-service world, then that provider is incentivized to continue to see that person on an ongoing basis because their productivity looks high and their engagement rates look high. But some of those other more high-risk client populations, they might have a serious mental illness and potentially are are not showing up for those services on an ongoing basis. And so there's going to be a more intensive intervention that's needed. And so really helping staff to feel those wins, understand the purpose behind it, and to ensure that you are incentivizing folks to be looking at how they are engaging with those higher risk populations. So it's not that it doesn't feel like a failure anymore. And understanding why we're focusing on these particular metrics. So these are the metrics that Washington State has identified in their roadmap around that clinics will ultimately be responsible. In the whole, obviously there are still metrics that are designed for each of the projects that folks are focusing on within DSRIP. But in all of the metrics that Washington is looking at, these are statewide, these are the 3 metrics for clinics. And so I point these out because this is really where you could also think about how this rolls up into what the state is looking at. So antidepressant medication management, potentially avoidable use of emergency room, and plan all-cause readmissions. And so thinking about what are the types of metrics as an organization you're going to need to be collecting that are going to roll up into these 3 metrics, taking into consideration the specific the very specific projects that you're working on within DSRIP as well. Next slide, please. So, one of the things that I would really recommend that folks are thinking about as you are developing your communication plan with staff is why population health management. Population health management is something that we talk a lot about, but what I end up finding out is that people sometimes are very confused about what it actually means. So I wanted to talk through an example of how one state has funded a case rate example of a value-based payment that is focusing on trying to support a vulnerable population, a vulnerable Medicaid recipient population. And so talking through New York State's approach to care coordination, they're using a health home model, and it helps you to flesh out exactly what a case rate might look like within a state. So, so essentially, the health home approach is trying to provide care coordination for those really high risk, vulnerable populations. And so in order to do that, how New York State has operationalized that is they had to first determine what the eligibility for health homes was. So they answered the question getting back to what is the need, right? So that Tracy talked about. How are we going to provide services to keep those patient populations that are of the highest risk out of the hospital to lower costs and also to make people have a successful and safe experience in the community and have access to the care that they need? And so one of the questions that organizations must ask themselves as they are pursuing should we be pursuing this as a potential funding stream for my organization is, thinking through who would be eligible for that health home benefit. And so as I was looking at this for an organization when I was an administrator, I was thinking about what is the eligibility requirement. And so for New York State, this is an example. It's 2 or more chronic conditions or one single qualifying chronic condition. And those chronic conditions could either be HIV, AIDS, or serious mental illness. And the substance use disorder qualifies as a chronic condition, but does not in and of itself qualify somebody as an individual for health home eligibility. So it must be paired with another chronic condition. And so what I did with that information is to take a look at, based on my diagnosis, data from my diagnosis from my EHR, I was able to determine the number of patients within my organization, the number of clients within my organization who were either diagnosed with 2 or more chronic conditions or one single qualifying chronic condition. And based on that information, I was able to take a look and say, oh my gosh, I have a huge patient population that could really benefit from this. And that helped me to make the decision of, I've got a really high risk patient population that I need to be attending to. So next step was to take a look at what are the case rates that were tied to each of those. And so here you can see literally how New York State thought about how they were going to set case rates for high, medium, and low risk patient populations. So they're still within health homes, which is the highest risk of all of the folks that are Medicaid recipients. There's an even higher risk, and those are the HARP folks, folks that benefit from HARP services. And so I could then take a look and do some modeling out of what I would actually be able to, how I would actually be able to serve that patient population based on the number of folks that I had that would qualify for each of these categories. So I had to tie it to reimbursement. I had to tie it to care pathways. I had to tie it to the creation of operational efficiency, and I had to tie it to margins. This is important for how we are identifying risk, because if I didn't do this correctly, then I am putting myself as an organization at even further risk. It is important that as we're talking about, I think that in the past, behavioral health has had a tendency, organizations have had a tendency to not talk about the financial pieces with clinicians. And I think it's really important that clinicians have an understanding of both how and why we're making these changes, why we're doing risk stratification, both because it's going to improve the overall health and well-being of the clients that they're serving, but also how that affects the your organization, and so that they can be a part of a solution, so that they can be a part of ensuring that there's organizational health and wellness as well. Next slide, please. So here's the part that I find that clinicians get the most excited about. So we're moving away from cookie cutter care plans. And so you're able to communicate to staff what the difference in caseload size might look like based on acuity of client population. And so, one thing that folks, I've worked with lots of folks that had questions about, well, I've got a caseload that's really high, and maybe I see folks or really high risk because I've got a lot of people that have a diagnosis with schizophrenia, and that's such a population that I work with and I work well with, and it's my specialty. And Kate, if you're saying to me that we have to reduce the number of if you're saying to me that I can't see somebody for a longer period of time, and we're going to be looking at length of service and all of these things, how does that fit for my patient population? But instead I was able to say, no, let's understand it. Our main goal here is ultimately to make sure that people are kept safe in the community. And so we can do that and be innovative and think through new ways of being able to support our patient populations. It's not one size fit all. It makes sense that somebody who has a specialty in serving a patient population with severe mental illness, that their caseload and their interventions and their care pathways might look a little bit different than somebody that has a lower risk caseload. So communicating with staff those differences, making sure that you are thinking through those nuances and giving them an opportunity to weigh in, thinking about comprehensive care management, care coordination, and comprehensive transitional care, so that they understand that there's a real focus on things like when somebody's coming out of the hospital. How might we behave differently in a care setting if somebody is transitioning from an inpatient unit to an outpatient unit? The use of health information technology to link to services, I mean, that's a big one. I know it can oftentimes be really frustrating for folks as they are trying to leverage technology, because it's both such a blessing and it's also such a frustration as well. So making sure that people understand what the true benefit of that is. And then doing what we do best. I mean, in behavioral health, we are so good at social determinants of health. And so how do we elevate that and talk about how we can think about community and social support services in a very different way? So ensuring that folks are really a part of those conversations and opening it up to their innovations about how we get there, right? So including staff in in defining the why, including staff so that they feel passionate about the why, and including staff in the plan to get there. As administrators, I know, at least for me, I always felt like there was a lot of weight on my shoulders to come up with the solutions. And whenever I let go of that weight and included people in some of those decisions that I made, I felt like they were just much more sound, and I had a whole team rallying behind me. And so I say that I really offer you guys the opportunity to talk some of that through now if people have questions. I also want to talk about next steps really quickly before I open it up to questions. So maybe if you have any, you can start raising your hand and we can call on you, or you can enter things into the box. The next steps here are we have a webinar on Wednesday, January 17th, and that is taking your project plan. So all those plans that you guys have been putting together, and if you remember, we talked about transitional change versus transformational change. So taking these smaller transitional change pieces and thinking about broadcasting that into transformational change. And what will that transformation plan look like? In the next couple of weeks, we're going to be sending out to the next week, I guess we're going to be sending out the value-based payment planning guide. So that should also help you to think through and prepare for that webinar in January. So see a draft of that coming out in the next couple of weeks. And then also we're going to be having affinity group calls. The second round of that will be happening in January. And so you can see when those are scheduled here. And if there's anything that you need before then, you are more than welcome to reach out to us. But also, any questions or comments, Libby?
We don't have any yet, but if anyone has them, please feel free to send them through. Oh, it looks like Natalie is raising her hand, so I will go ahead and unmute you, Natalie.
Hi, Natalie.
Hi. I have a quick question. In my discussion with my team yesterday about the non-emergent visits to the ER and about tracking them for our patients that come into our residential program, one of the things that they kind of had a question about is I was trying to get really involved in it and say non-emergent versus emergent. And what they said is, really, we feel like it's just ER visits because that's what is putting the strain on the financial piece. I wanted to get an idea of what you thought about that in regards to, could we just change what we're doing to, instead of non-emergent ER visits, just ER visits in general? I feel like it's too basic.
Well, so I think what you're struggling with is how do you define that, right? Is that?
Yeah, because a lot of the women that come into our PPW program may feel like, you know, an earache is an emergent visit, and so how do we?
Yeah, one of the things that I would, you're going to find a definition through the process, is my guess. And so what I might say is start with all emergency room visits. One of the things that I put into place is let's track on 100% of ER visits, let's track on 100% of hospitalizations, and let's do a deep dive, or let's do a root cause analysis on all of them to understand what the contributing factors were. And that doesn't mean that I needed to be involved in all of them. It meant that if somebody went to the emergency department or somebody went to the hospital, that in clinical supervision, that week you were going to process that with your supervisor or do an analysis, and then we talk about it and look for themes and try to understand it, not place a weight on good or bad, but by focusing on those things you end up seeing progress over time, inevitably, in your ability to impact non-emergent ED visits.
Okay, so in saying that, and that's from the clinical standpoint, I see that. How does it translate to helping my payers understand?
Well, it's that benchmarking progress. So I would say you want to make sure that you have you have a baseline and you're collecting that data over a period of time. So whether that's, you start with 1 month and then 3 months and you collect that baseline, and what you want to start to see is that you're documenting the decrease in those non-emergent visits. And that is what you start to say to payers, look at what I've been able to do, and or for this specific population, here's what someone else's data looks like, and here's how we've been able to keep people from going to the ED. And at the same time, we have other health indicators to say that they're also thriving in the community.
Okay. All right. I was just worried it wouldn't be enough to translate to our payers as a value in the service that we do. But I understand what you're saying, so it will translate.
It will translate.
Okay. Thank you so much.
No problem. Thank you.
Looks like that's all the questions we have for today.
Well, thank you. I before Libby ends us, I just want to extend my thank you so much to Tracy for being here today. Really, really appreciate it. And it's always such a pleasure to get to work with you all. And I look forward to talking with you guys again in the new year. I hope everyone has a wonderful holiday season.
Great, thanks, Kate. So one final thing before we close today, there will be a brief survey following the webinar, and we would really appreciate any feedback that you have. As always, please don't hesitate to reach out with any questions, and have a great rest of the day.